Dr. Epperly, welcome to our committee. If you'll state your name, please, for the record.
Ted Epperly, family physician, Boise, Idaho. Chairman Hyder and the members of the Senate Health and Welfare Committee, my name is Dr. Ted Epperly of the Family Medicine Residency of Idaho, in which I'm the CEO. I was appointed by the governor and currently serve as the chair of the Idaho Healthcare Coalition, overseeing Idaho's State Healthcare Innovation Plan, and also was honored by being appointed by the governor to serve on his Medicaid redesign work groups. Today, I will provide some background context for Senate Bills 1204 and 1205 as they relate to the governor's work group recommendations. First, and I want to make this really clear, I applaud Governor Otter for continuing to seek solutions for those who fall into Idaho's coverage gap. It is a credit to our governor's leadership that he appointed a broad range of experts from across the state to study this issue and the options available. And he continues to try to do what he thinks best for Idahoans. When Governor Otter first convened the Medicaid redesign work group in 2012, the charge to our work group was to study and recommend whether Idaho should accept Medicaid expansion funds as provided in the Affordable Care Act, to provide coverage for Idahoans earning less than 138% of the federal poverty level. The work group obtained a broad range of information to inform our recommendations. Levitt Partners provided an overview of the GAP population, their demographics, and their health needs. Milliman provided actuarial analysis of costs and savings to the state if Idaho accepted Medicaid expansion or rejected it and continued its indigent programs. After considerable analysis and discussion, the work group voted unanimously to recommend that Idaho accept Medicaid expansion. However, there was not a legislative initiative to consider this proposal. Given the lack of legislative interest in straight-up Medicaid expansion per the Affordable Care Act, the governor recommended and reconvened the work group in 2014 with a different charge. This time, the assignment was to study alternative plans being put forward by other states, as the Centers for Medicare and Medicaid Services had shown unprecedented flexibility towards states who wanted to cover their gap population, but structure the program differently. The work group studied a number of different waiver models and ended up developing our own hybrid model that accomplished several key objectives. Number one, we kept those from 100 to 138% of the federal poverty level in private coverage through Idaho's health exchange, Your Health Idaho, creating a private option. Number two, we placed those below 100% of the federal poverty level in Medicaid managed care, incorporating healthy behavior incentives and the maximum personal responsibility in the form of cost sharing allowable by CMS. Number three, we encouraged access for patients to a usual source of care through the primary care models of the patient-centered medical home and direct primary care. Number four, we created provisions to protect Idaho in case Congress should ever decide to shift more of the funding burden to the states beyond the 10% maximum the states were to pay, as per the Affordable Care Act. In that instance, Idaho's program would be discontinued. And lastly, we included ongoing dialogue with CMS to ensure that Idaho's waiver plan would be accepted once approved by the Idaho legislature. So it explains simply the difference between Senate Bill 1204 and Senate Bill 1205. The first, Senate Bill 1204, represents the work group's first recommendation in 2012, straight-up Medicaid expansion, as per the Affordable Care Act. Senate Bill 1205 represents the work group's second recommendation in 2014, which was the hybrid private option model developed in Idaho by Idahoans for Idahoans. We call this plan the Healthy Idaho Plan. Key similarities and differences between Senate Bill 1204 and 1205 are the following. Both would eliminate the state catastrophic fund and the county indigency fund, as patients served by our indigency programs would obtain coverage, thus saving Idaho approximately $55 million per year. Both would provide patients the full range of essential health benefits, including primary care, prescription medications, diagnostics, behavioral health care, specialty care, ER utilization, and hospitalization when necessary. Senate Bill 1204, the straight expansion model, would pull those from 100 to 133% of the federal poverty level who are currently in private exchange plans into Medicaid. Senate Bill 1205, the Healthy Idaho Plan, would keep this group in the private exchange plans. Since 2014, through the $40 million State Healthcare Innovation Planning Grant, known as SHIP, Idaho has been transforming our healthcare system to better provide accessible, integrated, and coordinated primary care through the development and scaling of the patient-centered medical home concept. According to the Commonwealth Fund, two things drive better healthcare outcomes for populations of people. Number one, a usual source of care, and number two, some type of insurance coverage. Senate Bill 1205, the Healthy Idaho Plan, will provide the comprehensive insurance coverage that will align with the SHIP transformation of our primary care system and provide both a usual source of care and a comprehensive insurance coverage plan. For time purposes, I will not show any slides, as I want to ensure time for discussion and others to be able to present. So in closing, our hope today would be that you vote to send the Healthy Idaho Plan, Senate Bill 1205, to the floor with a do-pass recommendation. This plan represents 3 years of hard work by Idaho experts on the governor's work group, and it represents a tremendous opportunity to save taxpayer dollars by leveraging Idaho's share of federal dollars back to the state and eliminating wasteful county and state programs that would no longer be necessary. Not to mention the greater reason to do this, which is saving and improving Idaho lives of low-income working Idahoans who fall into the coverage gap and because of this live sicker and die younger. Thank you for your time and consideration. And Mr. Chairman, I stand for questions that you and the committee may have.
Thank you, Dr. Epperly. We certainly appreciate the information you've given us. It's been very informative. Senator Hagedorn.
Thank you, Mr. Chairman. I appreciate you being here, Doctor. You're the perfect guy for this question. If we were to do this, do we have the doctors available in Idaho to accept these added Medicaid patients?
Yes. The bottom line answer is yes, Senator Hyder, Senator Hagedorn. But here's how we need to leverage it. We do have a shortage of primary care physicians, but per our earlier speaker, who brought 3 issues to you all, nurse practitioners and PAs would also become part of the solution. We have an expanded workforce that could care for Idaho's population. We'll need to continue to build out the primary care workforce, but sir, yes, we could make this happen.
Thank you.
Are there any other questions for Dr. Epperly? Doesn't appear so, Dr. Epperly. So thank you very much for your testimony. I do have one question, and that is, when you compare this plan with the governor's plan, which I'm sure you've read as well, what is the difference and where is the funding source?
Right. Senator Hyder, thank you for that question. There are distinct differences between the plans. On the Senate Bill 1205 and 1204 side, this is comprehensive insurance coverage. This covers all services that a person may find themselves needing, from primary care to subspecialty care, to lab work, to x-ray imaging, to potential ER utilization or hospitalization. The governor's proposal in the Primary Care Access Program is only for limited primary care, meaning that what will be served for people, and it's important, is a usual source of care, so that people will be granted the opportunity and will be impaneled to primary care practices throughout the state to receive that primary care service. That'll start to coordinate care, that'll start to provide the type of care they need, but sir, it will not go far enough in regards to any potential other issues that might happen. So let's say I diagnose a patient of mine with breast cancer. That patient may need further imaging, chemotherapy, consultation with an oncologist, may need hospitalization. Those services would not be covered. So it is a distinct difference in that the two bills we're discussing now is a complete insurance program, whereas the latter program is only a partial delivery program. The two bills that we just talked about would provide both services, complete coverage and a usual source of care. It's a more inclusive and comprehensive package. In regards to the cost analysis, just let me say that in looking, and I think that Senator Schmidt wanted to mention this in his concluding remarks too, but in looking at both the programs, what Senate Bill 1204 and 1205 will do, basically because of the cessation of the State Catastrophic Fund and the County Indigency Fund, will save Idaho roughly anywhere from $25 to $35 million a year. Whereas the Primary Care Access Program will cost upfront $30 million to start and to pay primary care for the services, but will not stop the County Indigency Fund or the State Catastrophic Fund. So in aggregate, will cost the state $85 million. So we have a program that will potentially save the state $25 to $35 million per year, but on the other hand, will cost the state $85 million per year. The other thing that I would just quickly also add is that in looking at the funding that goes to states that have expanded Medicaid, which there are 30 states now of the 50 in our country, what it would bring to Idaho is $577 million over 10 years. Now, studies have been done on that amount of money. That's roughly $57 million per year in addition to the cost savings. And what that has been shown by University of Idaho experts is that the positive economic impact of that is roughly about $1 billion a year to the economy of Idaho. So, sir, those are the salient financial differences between the programs.
Okay, thank you. Are there further questions for Dr. Epperly? Okay, doesn't appear so. Dr. Epperly, thank you for your time today, and we certainly appreciate your expertise.
You bet. And thanks for your time as well.